Get my quiz for the day. There. Anyone seen Emma? Yeah, it sounds like from her email, she's really struggling.
Yeah, she was trying to go today and then there was a sign in it for soccer and so she tried to go, but she was kind of slipping around with her crutches. And I think she's pretty sore. She said,
I get the impression from her email she's in a lot of pain still. And I don't know if you guys saw this in the paper in your news feeds. There's a massive drug shortage right now in the US, particularly of painkillers. So even if the doctor wanted to treat her pain, could be the pharmacy just doesn't have the medication. It's an ACL repair. That's a big deal. Okay, hopefully she'll be on here soon. I was slow getting that to her, so I hope. Okay, forgot about it or something. Oh, right on that. All of that. Water back in the saddle. Yep. She wants to get back in the saddle.
I know, I think she tries to get out and then she like gets too tired and too much contained and then she can't make all the classes and she feels so bad. Yeah.
Yeah. That's the nature of the beast. Where are you, Emma? Anyone has Emma's number? Can you text her really fast? Say, we started. I sent you a Zoom link. Jump on. It could be she's too tired, which is fine. But if she wants to come, I just want her to know that we're starting. All right, so when we consider the brain, different parts of the brain are associated with different abilities. Consequently, damage to different parts of the brain will tend to affect those various abilities. So when we look at the frontal lobe, piece of the frontal lobe that borders that fissure between the frontal lobe and the start of the parietal lobe, that is your prefrontal gyrus. That's your primary motor cortex. You see it there. And then the area in front of that is the so-called supplementary motor area. So the primary motor cortex is responsible for initiating for actual movement. And in A and P, you probably looked at the motor homunculus, where the lower extremities are controlled largely by parts of the motor cortex that are towards the top. Then as you go this way, it kind of works its way up. So lower extremities, arms, face, so on and so forth as you go down the motor cortex. So in front of that, the primary motor cortex is involved with planning, motion, and things like that. So damage to the supplementary motor cortex won't affect movement directly, but it will affect executive decisions about movement. So just consider a very simple movement like, well, I'll put it up here so you can see it. Say you're thirsty, you want to drink, you're planning movement. Now, you don't think about, okay, I better flex this, inhibit that, so on and so forth. But by looking at it and planning it, there's sensory information that this area is extracting. Then it's deciding essentially how to move. And then there are several ways you can move. You can move this way or this way. You could reach, you could grab here. No, you'll grab there based on sensory information. There's all planning in that. So trouble with the supplementary area, you're still able to move, but you're going to either miss it or you'll reach too far or something like that. Damage to the cerebellum. Remember, the cerebellum coordinates for perception and movement. With the cerebellar damage, you get what's called intention tremor. You don't have tremors at rest, but as you start to get there, you then will start to, that's intention tremors. So for example, if I asked you to do this, you'd be fine here. The second you got up here, you'd start to. So that sort of intention tremor, when you intend to move, then you start to get a lot of movement that will slow down. That's intention tremor. That's at the cerebellum. The other thing cerebellar damage will do, it causes this condition called ataxia. Ataxia. So you have no damage to the motor area. You can move, but the movement's not coordinated. So with ataxia, you have movement. When you walk, you will move towards the side where there's damage. So if there's damage in the right cerebellum, you will tend to have a staggering gait, almost like you had too much to drink. And you'll move towards the side of the damage. Whereas, if you have damage, say, on the right motor cortex, it affects the left side. So it's contralateral to the side of the damage in the case of the motor cortex. It's ipsilateral in the case of damage to the cerebellum. In front of that, you have the prefrontal association area. This is really all about putting things together, executive functions, things like that. Behind the central sulcus, you have the primary somatosensory cortex. This is all about sensory information. So all those pseudounipolar sensory neurons that whose cell bodies are in the dorsal ganglia, running down essentially up and down your spinal cord. They will project eventually to the primary somatosensory cortex. And once again, you have this homunculus, parts of it essentially that map to different parts of the brain. Tends to go lower limbs, then upper face, and so on and so forth. Behind that, you start to get areas involved in auditory association, visual association, somatosensory association, parts of the brain essentially that take sensory information and put it together and make sense of it. In the temporal lobe, you have, of course, the primary auditory cortex that you see on top, the temporal lobe. Then you have areas associated with visual association. If you're to take the temporal lobe off, there'd be another lobe that you don't see. That's called the insula. Did you guys talk about the insula? Maybe. Okay. Do you remember what the insula does? I'm going to take that to be no, since I'm hearing science. So the insula is involved with emotional states, but the insula is also very important for processing olfactory sensation, because the piriform cortex is on the inside of the temporal lobe, and it associates very strongly with the insula. Emotional states and also taste and olfactory processing. Then the limbic cortex, which that regulates very much emotional states. The olfactory tracts go straight, they don't go through any sort of, they don't go through the thalamus. They go straight into the cortex, and they tend to communicate straight with the limbic system. That's the reason why smells can evoke one, very powerful memories, two, very powerful emotions sometimes. When you think of a very powerful emotion like disgust, disgust is often evoked by olfactory sensation. So think if you open the refrigerator and that lasagna that you just forgot about, it's been in there, maybe a month or two or something like that, and you look at it, it's kind of velvety, and then you open it up, and that powerful scent of degradation just strikes you, and you feel disgust, and you chuck it out, and then you acid wash the container, which goes in or something like that, or maybe use bleach. Maybe you're more sensible than that. And that's the reason for that, is that those sensations go through the limbic system. In the back, you have the primary visual cortex, and then you have the visual association centers. Those are involved with processing. And those have extensions as well to other centers in the parietal lobe that help you recognize faces and things like that. Then in the brainstem, you have a variety of different centers that control breathing and heart rate and things like that, what have you. We're going to talk about strokes in the next chapter. Just keep this in mind. You have three main arteries that feed the brain. You have the anterior cerebral artery, middle cerebral artery, posterior cerebral artery. Got the circuit process? No. All right. Quick circulatory lesson. So the carotids, common carotids branch into the external and internal carotids. The internal carotids come up and they fuse with actually a circle. A vessel is called a circle of Willis. There are several basal vessel. So that circle, you've got these things called communicating, anterior and posterior communicating vessels. There are three sets of main vessels. These vessels are paired. The anteriors come off and go up like this, and they're essentially going to feed kind of a mohawk of your brain. So the anteriors feed the mohawk. The middles are going to feed, no, Emma. Come on, Emma. The middle is going to feed like here. And then the posterior, let's get a different color here for the posterior. The posterior essentially will feed something like this. And then your anterior will feed this area here. So if you have a stroke that affects the anterior vessels, you're going to have trouble usually with your lower extremity. You'll usually have loss of feeling and loss of use of your lower extremity. If you have a stroke in the middle, you're going to affect language acquisition and sensory processing. If you have a stroke in the posterior cerebral arteries, you will affect usually vision and visual processing.
And if you have a stroke lower down in vessels that go to the circle of Willis in the brainstem, then you may have trouble with visual movement. And you may also have trouble regulating breathing and stuff like that. And in the basilar artery, if you have a stroke in the basilar artery, you'll have locked in syndrome, where you can't move at all. So you get a little head start when you get to the circulatory system. Same thing with damage. If you get a blow to the head that causes a lesion in various parts of the brain, so in basketball, correct me if I'm wrong, a lot of the injuries when you go up are usually from elbows. Elbows usually to the side of the head. Now, the side of the head, actually that bone is thin, and there's a vessel called the middle meningeal artery, the MMA. Very appropriate. That if that gets broken because of this thin area, it'll bleed like nobody's business. And then you get a bleed inside the brain. What's that going to affect first? Which part of the brain is that going to affect first? Top, middle, or bottom? So that vessel is right in this range here. It's right around here. That breaks, you get a bleed right here. So it's going to affect this area right here. So think about the sorts of things that will be affected. So Kylie gets an elbow to the head. That's true. She goes down. Chris comes over. Chris says, "Okay, Kylie, follow my finger. I'm gonna play. Go away. Fine. Okay, which everybody says. Don't believe it. Don't believe them. Because you got hit right there, language acquisition, hearing. Okay, Kylie, can you hear me? Yeah, I can hear you. I want to play. Okay, Kylie, what's today? Oh, it's Friday. Don't be silly. It's Friday. What season is it? It's winter. There's snow outside. Stop it. I want to play. Okay, well, we evaluate you more. No. Coach. Okay, now what's coach going to say? Because coach is more concerned about your well-being than winning the game. Well, John's a good shot. So you're gonna have to sit and undergo further evaluation. What if you have a bleed? And then all of a sudden you're sitting there and all of a sudden your eyes roll back to your head or something like that. You're out on the court and you take a tumble, it'll make it a lot worse. Or if you're sitting and Chris can watch you, then it'll be much better. So those are all things to look at. And this slide here essentially just shows you that if you have various types of disruptions of various neurotransmitters. So several different types of antidepressants increase serotonin. Infection can increase serotonin. So can hepatic encephalopathy because of lots of ammonium in the body. Other sorts of things can decrease GABA. GABA, remember, is an inhibitory neuron. Benzodiazepines will tend to increase GABAergic neurotransmission. They tend to be neuronal suppressors, whereas alcohol withdrawal will tend to decrease it. You tend to get more neural activity. Surgery, age, dementia, so on and so forth, blah, 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 what have you. These are just things to consider when it comes to certain types of events and their effect on neurotransmitters. Very good. Let's talk about dementia. So dementia is the gradual loss of faculties, gradual impairment of intellectual processes. So you'll have loss of orientation. Orientation meaning, or orientation with respect to place and time and what have you. Orientation with respect to memory, particularly short-term memory.
Loss of language skills. People need to find words and things like that. Losses in judgment and losses in decision-making. Dementia is usually involved with some sort of neuronal degeneration. The mechanism of neuronal generation is going to differ from dementia, one dementia to another. Any sort of brain tissue compression can also cause dementia. So, for example, there's something called normal pressure hydrocephalus. With normal pressure hydrocephalus, because the ventricles in the brain are expanding, the pressure in the cerebrospinal fluid stays the same. A little bit deceiving. So as the ventricles expand, what's the brain going to give up for those to expand? Neurons. So it's starting to kill off neurons as this happens. And so the signs of normal pressure hydrocephalus, NPH, is WWW, wet, wobbly, and wacky. Wet because you lose urinary continence, wobbly because you start to have ataxia, and wacky because you have dementia. That's due to this neuronal loss due to compression. Urinary incontinence, ataxia, and intellectual degeneration. Dementia. Atherosclerosis, there are lots of good association studies, clinical studies, what have you, that show that atherosclerosis can increase the risk for dementia. Decreases blood flow to the brain. By decreasing blood flow to the brain, you don't feed the neurons as well, and it decreases your ability for the brain to get rid of toxins. So atherosclerosis can definitely accelerate the risk of dementia. And of course, brain trauma, and with this, we must say repeated brain trauma. Repeated brain trauma. Dementia is something that can run in families as well. That's something to keep in mind. So let's talk about some of the different types of dementia. The first type is probably the most famous. That would be Alzheimer's disease. So in the membranes of neurons, there is something called amyloid precursor protein, which is abbreviated APP. What APP does is still highly debated. There's been so much work on this protein, and there's no real agreement on what it actually does in the body. Some nuts are just hard to crack. So APP normally gets chopped up by a couple of enzymes. And these enzymes are called alpha secretase and gamma secretase. And alpha secretase and gamma secretase release APP from the membrane. And this then goes off to get chopped up, and no one's the wiser. Well, there's another enzyme called beta secretase. And beta secretase teams up with gamma secretase instead of alpha secretase. If it does, it clips APP in two spots, here and here. And it makes this piece that is 42 amino acids long called A beta 42. A beta 42. Oh, that looks absolutely dreadful. My 2 looks like a scribble. There, A beta 42. A beta 42 is not soluble. Not only is it not soluble, it will take, it folds into a particular shape that can take other proteins and force them to fold into this abnormal shape. And so it forms these clumps full of abnormal proteins, and they form these things called amyloid plaques. Now, there is debate as to whether the amyloid plaques cause Alzheimer's or whether they're simply a consequence of Alzheimer's. That's a debate. Most neurologists think, yeah, it causes Alzheimer's. And most of the drugs that have been designed to fight Alzheimer's have targeted the formation of those plaques. Whatever the case, the presence of these plaques in the brain is diagnostic for Alzheimer's. And these plaques are inimical to other neurons. They are the plaques, they get big and they are toxic to neurons. They will deposit around blood vessels. They'll weaken the walls of the blood vessels and increase the risk of hemorrhage. They'll cause something called amyloid angiopathy. And the neurons have supporting their axons these networks of microtubules. And one of the proteins that helps the microtubules hold together is a protein called tau, T-A-U, tau. And because the neurons will start to die off, their microtubules and the tau in the microtubules gets very heavily phosphorylated. And the phosphorylated tau takes the microtubule proteins, tubulin, and it just takes them and mushes them all together in this stuff called a neurofibrillary tangle. And you can see the formation of those neurofibrillary tangles up here. So the tangles are found inside cells, as opposed to the beta amyloid plaques that are found outside the cells. The neurons with tangles and non-functioning microtubules can't function as neurons, so they off themselves. And those number of neurofibrillary tangles increase, and you get very low acetylcholine levels inside the hippocampus and inside the basal ganglia. So that contributes to the cognitive symptoms of Alzheimer's disease. That's why many of the drugs that are used to treat early Alzheimer's disease tries to increase acetylcholine levels inside the brain. Alzheimer's disease can be either sporadic or familial. Sporadic describes the late onset type, And that's probably a combination of genetic and environmental risk factors, and it accounts for most cases of Alzheimer's disease. Familial Alzheimer's disease is inherited, and it tends to be more, it tends to show an earlier onset. So one of the causes of familial Alzheimer's disease is due to mutations in a gene called presenilin-1. Presenilin-1 is found on chromosome 14. And then presenilin-2, which is on chromosome 1. So about 10% of all cases of familial Alzheimer's is due to mutations in presenilin 1 or 2. Presenilins are part of the beta gamma secretase complex. And then the APP gene is found on chromosome 21. People with Down syndrome have extra copies of the APP gene. They're at higher risk for Alzheimer's as well. So here's the postmortem brain of an Alzheimer's patient. Look at that and tell me what you see. Can we agree that doesn't look normal? What's wrong with it? Should the ventricles be that size? Grace is right. Haley's right. Yeah, they're huge. They're absolutely huge. They're way too big. So those ventricles are enlarging as cells are dying. Also, look at the folds, the gyri and things like that. Look how deep they are. That's a brain that's undergone extensive degeneration. Also, alterations in genes, the gene that encodes apolipoprotein E, in particular the E4 allele. People with this allele of the ApoE gene are also at higher risk for sporadic forms of Alzheimer's. And so you get forgetfulness, emotional upset. People become worse usually towards the end of the day. That's called sundowning. Disorientation, confusion, lack of concentration, decline in intellectual capabilities. So my mother was one of the first female brokers ever hired by E.F. Hutton. Mom could do, she balanced a checkbook without a calculator. She'd do it all in her head. I sat there and the doctor said, Lucy, can you subtract 7 from 93? I said, no. That was hard. That was hard. So you can see that the Alzheimer's brain, there's just less tissue there. And as you go through here, you see less tissue, you see amyloid plaques, you see cells dying, they're full of neurofibrillary tangles and so on and so forth. Any questions about Alzheimer's? Frontotemporal dementia refers to atrophy to the frontal lobes, and that atrophy then progresses to the temporal lobes and then parietal and then occipital lobes. There is a subtype of FTD called Pick disease. Pick disease
And Pick disease shows neurofibrillary tangles. So once again, you have tau protein that gets hyperphosphorylated. It causes neurofibrillary tangles. The neurons stop working, they die, they start to stick together, make this insoluble mass inside the brain. Most cases seem to run in families. They seem to have genetic factors that contribute to them. There are some other types of seizures. The one that I think is worth mentioning is vascular dementia, where you have atherosclerosis that forms in the artery supplying the brain, like the internal carotid artery. You decrease blood flow to the brain, and the brain experiences chronic ischemia. Chronic ischemia. That chronic ischemia will tend to cause the brain to very slowly lose function. Sometimes those atherosclerotic plaques can break off, they can float into the brain, and they can cause embolic strokes. Typically with vascular dementia, people will lose function in a stepwise fashion as they start to get several strokes that start to do this to the brain function. There are a few other types of dementia, but we don't have time really to talk about them. Any questions about dementias before we move on to something else? Here, where did I put that? Great, I left it someplace else. Okay, yeah. Okay. Put it there? No, didn't put it there. Now, in the brain, you have neurotransmitters that activate and neurotransmitters that inactivate. You have those that cause excitatory postsynaptic potentials and those that cause inhibitory postsynaptic potentials. So usually you have a balance between those two. So that areas that become active are usually shut down by inhibitory circuitry. Also, inhibitory circuitry prevents activational circuits from overactivating. In the case of seizures, the circuits that prevent activational circuits from overflowing their shores, shall we say, don't work properly. And this activational circuitry activates the part of the brain, then that starts to spread to other areas of the brain. And then you start to get more and more and more and more activity. Now, seizures can be either generalized, where they involve both hemispheres of the brain, or they can be focal, where they just involve one hemisphere of the brain. Generalized or focal. Seizures can manifest in several different ways. So the tonic-clonic seizures, as they're called, tonic-clonic seizures, they are the ones that are definitely, that you're probably the most familiar with. So tonic-clonic seizures, those are almost always generalized seizures that involve both hemispheres of the brain. So if some activity, that activity then spreads to both areas of the brain, and you now get these motor manifestations where you have a series of clenching, relaxing, clenching, relaxing, clenching, relaxing, clenching, relaxing, clenching, relaxing. Those are your tonic-clonic seizures. That's when you think of epilepsy, that's normally what you think of. Now, it turns out that's not the only type of seizures. You can also have focal seizures that start in one place and tend to stay on one side of the brain. So for example, you can have a particular type of seizure called a myoclonic seizure. Myoclonic seizures involve, they're almost like a tic. So golfers have this phenomenon they sometimes call the yips or something like that, where you kind of putt. And all of a sudden you're stressed or something, and you do this and you get the ball. My uncles or somebody who comes up and you just, I mean, you've had the yips on the putting. Yeah, well, okay, happen to be that, and the worst too. Myoclonic seizures can literally be something like this. That's literally what a myoclonic seizure might look like. Where'd that go? And myoclonic seizures typically, the difference between them and tonic-clonic seizures, that myoclonic movements are very fast. Whereas a tonic-clonic seizure, you might have a movement, say, every 5 seconds or 2 seconds or something like that. Myoclonic seizures, you'll have several movements per second. They're very fast. Most myoclonic seizures are short. Not all of them are short, but most of them are pretty short. The other type of focal seizure you can have is an atonic seizure. These are very short, 1 to 2 seconds, but you lose muscle tone, and all of a sudden you just, and they're sometimes called falling seizures, or people will call them the drops. That sort of thing. Dropsy, the old name for it is dropsy. And this can be very dangerous if someone, say, is, so they're waiting for the bus or something like that, and all of a sudden they get an atonic seizure and they just fall. You whack your head. So this can be potentially dangerous. Atonic seizures. Then something you will tend to see in children, but you can also see them in adults, is absence seizures. My niece gets these. All of a sudden, literally, the patient will stare at you and then just sit there. Yeah, what were you saying? And they won't remember essentially that period of time when they just zoned out. This is different from falling asleep in class or something like that. If you've known somebody with these, literally, they will just all of a sudden zone out and they're just like they're not there all of a sudden. Kids with ADHD, or rather kids with absence seizures, get mistaken for having ADHD, when in fact they're actually a type of seizure, absence seizure. Seizures can be caused by a variety of things. Strokes, for example, can predispose people to seizures sometimes. So can certain tumors, certain metabolic disorders, infections, high fevers, things like that, can introduce the possibility of seizures. So can various vascular diseases, substance abuse, things like that. All of these can cause seizures. So again, they're classified by their manifestation, classified by their site of origin. EEG does a very good job of usually telling you where in the brain the seizure originates. Some seizures start focal and then they become generalized. That's called secondary generalization. Secondary generalization. And epilepsy usually refers to tonic-clonic seizures. Seizures may have a prodrome. The patient may see kind of a fuzzy aura around what their vision, or their vision may start to all of a sudden go blurry, or they may, some report certain smells. There's a very interesting case I was reading about the other day. The patient said they smelled kerosene. If they said they smelled kerosene, they knew the seizure was coming. So there's the tonic phase of contraction, the clonic phase of relaxation. After the seizure, there's a so-called post-ictal phase. During the post-ictal phase, the patient will gradually regain some of their faculties. This business, like on television, where someone has a seizure, then after that they get up and do everything they thought they could do. You regain those faculties usually gradually. Some people may take a while, some people will get quickly. Focal seizures, you may actually have a period of paralysis. That's called Todd's paralysis. TODD, Todd's paralysis. Status epilepticus means you basically have seizures. They're either so close together or you just have them constantly. And that's a medical emergency.
What is the cause of like some sort of
That's a great question. More common in females, and it has to do with the flush of female hormones. Usually, female hormones, during puberty, you get them gradually. Some females get, instead of this, they kind of do this. And because these hormones affect the brain, they affect brain development, they affect brain function, and what have you. And some gals, and most gals who get this, they grow out of it. So they're usually not something to be too concerned about. That small cold comfort of that, frankly, which you guys will discover when you become that. That's a thing that there are most people. It's because you're worried more than about yourself. And you will go to your parents, you will apologize if you're single. Not having done that yet, but I'm waiting. Because of that, some women, and the thinking right now is that if you get these pubescent seizures, you're probably more prone to seizures in the first place. So usually that goes to your medical records, then you need to be watched because some medications lower the seizure threshold, which means you shouldn't be on if you have that in your medical history. The other thing that will increase the risk of that stress plus the hormones. Seems to be more than just the hormones. Stress plus the hormones to cause that. So, and some gals who get this, they have one seizure, and they can't drive for 6 months because that's the law. After that, which is a drag. They haven't, and that's the only seizure they have. So, my sister-in-law actually, that happened. So, and so she's got that in the record. So certain medications for the top limits for her seizure threshold supposedly is lower. I say supposedly because that's the thinking, and sometimes medical thinking is wrong. Turns out to be wrong. Seizures can also be caused by increases in intracranial pressure. And several things can cause increases in intracranial pressure. Probably the biggest one would be some sort of head trauma that causes a bleed. If you bleed into the subarachnoid space, you increase the pressure. The body, in response to that, if you watch their herniation video yet, the body will auto-regulate and will decrease the amount of CSF it's producing and try to increase the removal of cerebrospinal fluid. But if the bleed is like, say, the middle meningeal artery, the bleeding is just too fast. The increase in intracranial pressure is too much for the body to put up with, and you get essentially these different stages where pressure increases and you get different manifestations essentially as the pressure gets greater and greater and greater. Also, if you block the flow of cerebrospinal fluid then gets produced and it's not taken up anymore. Tumors can do that. So can certain types of trauma, certain types of swelling. So for example, the pineal gland, which makes melatonin, because the pineal gland is very close to the aqueduct of sylvius, which that's the old name for it. You guys learned it by a different name probably. It's now called the mental aqueduct, I think. The trend now is to not use names for things, which I think takes a little mess out of the matter, but that's me. If you get a tumor of the pineal gland, that'll push that shut. And that's one of the most common tumor causes of increased intracranial pressure. So tumors, hemorrhage, trauma, and certain infections. Because you get masses of organisms that can plug, exit, or they can damage the arachnoid granulations that remove the cerebrospinal fluid or something like that. When you have increased cerebrospinal fluid and increased pressure, usually your first signs are headache and nuchal rigidity, where the back of the pain in the back of the head, and then photosensitivity. Then as the pressure starts to increase and you start to impinge on areas of the brain, now you'll start to have things like decreased breathing, hypoventilation, tachycardia typically, as the cardiac centers start to be affected. And then as the pressure increases, you'll have loss of intellectual capabilities, loss of consciousness, so on and so forth. You're not supposed to do a spinal tap if someone has increased intracranial pressure. However, therapeutic spinal taps to remove pressure. Now, if you have a bleed, usually trepanation is usually what you do. You drill what's called a burr hole. You drill a hole in the skull and you let the fluid out. And that fixes it really well. That's, of course, an emergency procedure. The other thing you could use is diuretics. That will get rid of fluid, and mannitol is one of the diuretics that is usually used in those conditions. So increased fluid in the brain can be either internal or external. If you're having a bleed, that's of course going to be largely external. You can also have cerebral edema if you take in too much liquid. So if you have, this condition where you have psychogenic hypervolemia, that can cause cerebral edema. That can cause swelling of the neurons and their destruction. So excess fluid within the ventricles, that's hydrocephalus, and that's either caused by too much production or decreased resorption or some sort of obstruction. There are certain types of malformations that can cause this, and the ones that you see most often are called Chiari malformations. Type 1 and type 2. Then there's another malformation called Dandy-Walker malformation. So with the Dandy-Walker malformation, you have decreased development of the cerebellum. So it falls in between the foramen magnum and the spinal cord, and it cinches down the spinal cord. And because of that, you get blockage. So you get agenesis. That's a Dandy Walker malformation, so that, you'll see that in babies. You're born with that. Same thing with the Chiari malformations. With the Chiari malformations, the ventricular system itself has problems. And so you have blockages and what have you. The best way to handle these is through what's called a peritoneal ventricular shunt. All right, ventricular. So you have a hole that's drilled and you have a tube, and the tube essentially will take this excess fluid, put it into the peritoneum where it's resorbed and dealt with by the kidney, essentially. That's usually how you will treat things like Chiari malformations. Mind you, Chiari malformations and Walker malformations, it's also very common for kids to also have spina bifida with those malformations. And spina bifida can come in several different shapes and sizes. You guys heard of spina bifida? You know spina bifida. So the neural tube rolls up at about end of week 3, towards the end of week 3 of development. There's a hole at the front and top. The hole at the front, those are called neuropores. The front hole seals first. It seals about day 21 or so. The back one, the posterior neuropore, seals about day 22, 23. If that doesn't seal, then you get a lack of the formation of neural arches. And that is spina bifida. If that will usually cause a tuft of hair to grow on the back, and that's called spina bifida occulta. That's just the neural arches just are formed. If you get a bulge out, so the spinal cord is still there, but the meninges grow out, that is called a meningocele. Meningocele. Meningoceles can be repaired surgically. And if the spinal cord is out with the meninges, that's called a myelomeningocele. And that is not good. That cannot be repaired surgically, and the kid is going to be paralyzed from the waist down, and they'll probably have to be catheterized to deal with urine and stuff like that. So that's mainly what causes hydrocephalus when you have it in infants. So non-communicating hydrocephalus means that your blockage, you don't have communication between the different parts of the ventricular system. Communicating means you have proper communication, but you're making too much of it. You're overwhelming the ability of the body to reabsorb it. And the normal pressure hydrocephalus already talked about, wet, wobbly, wacky. Patient experiences edema in the brain caused by movement of CSF from the ventricles to the extracellular space. What type of edema does this describe? It describes ischemic, cytotoxic, interstitial, or vasogenic edema. Think about it. Who thinks A is the right answer? Who thinks B is the right answer? Who thinks C is the right answer? Who thinks D is the right answer? Come on, guys, you got to vote for something. Let's try that again and vote for something, please. Who thinks A is the right answer? Who thinks B is the right answer? Who thinks C is the right answer? Who thinks D is the right answer? The answer is C, interstitial. It's going out among between the neurons in the interstitial space, causing edema. The answer is interstitial in that case.
All right, oh goodness, I got 2 minutes left. Okay,
So if you have damage to the lower motor neurons, you will typically experience flaccid paralysis. If, however, you have damage further up so that the upper motor neurons are affected, now you will typically have trouble with reflexes and control of movement. So if you have damage, flaccid paralysis, lower motor neuron damage will have hypotonia. Upper motor neuron damage, however, you may have hypertonia and spasticity, uncontrolled movements, uncontrolled contractions of the muscles. So this can lead to rigidity,
not unlike what you see in Parkinson's patients. Remember the lead pipe rigidity we talked about, and then on the wrist, especially cogwheeling?
that would be an example of rigidity. That's due to damage in the basal ganglia. Dystonia is uncontrolled movements. So things like, where you get, people, and stuff like that, that would be dystonia. Gegenhalt and paratonia, where all of a sudden you try to do something and then you stop, you just can't do it. That's the motion essentially that is not fluid. You just keep halting. You have to essentially reinitiate movement each time. And then spasticity, just uncontrolled contractions of muscles.
Tardive dyskinesia is usually caused by medication,
In particular, antipsychotic medication. First place you see tardive dyskinesia is in the face. And it will usually involve movements of the tongue and the lips and things like that.
that's usually what you see with tardive dyskinesia.
First generation antipsychotics are more likely to cause it than second generation antipsychotics, but second generation antipsychotics in some cases can cause it, but first generation ones are the ones that usually cause it. Paroxysmal dyskinesias are usually the result of strokes or toxicities or something like that. There are some videos online I'd like you to watch. For example, there's something called Fallisms. You get essentially, if you have someone say to raise their hands up, you raise your hands up and then this hand is doing something like that. That's Fallism. That's a type of paroxysmal dyskinesia. Or there's another video called synonym chorea. There's this kid who had a coccal infection very early. It affects the caudate nuclei. And this kid can't sit still. He keeps doing this. And what happened? The doctor has him raise his hand above his head. He does this, and then he starts. Those are types of choreas. Those are also a type of proximal dyskinesia, things like that. Please watch those videos. We'll have more to say about those
Next time. So we will finish this and then get into chapter 16, starting to look at movement disorders and strokes and things like that.